When we talk about respiratory medicine in many forums and many ways, one of the symptoms that doesn't need a respiratory physician alone to know what they are talking about is cough. So this is the most common symptom a patient presents to the OPD with, whether it is the medicine OPD, a surgery OPD, a gynae OPD, a child's OPD, or a specialized OPD. Cough is probably one of the most common symptoms. And this is one of the symptoms that represent a variety of diseases. So cough is not a disease. Cough is a symptom that represents an underlying condition which may be very severe. But if diagnosed early, it is very satisfying to be treating a patient because it can cause significant decrease in quality of life. So when we talk about cough, let's just get some definitions out of the way about what is acute cough. When a cough is less than 3 weeks duration, which is usually of viral origin or inflammatory origin, it could be less than 3 weeks. So usually viral coughs these days, every house, somebody or the other has a cough who's had a viral upper respiratory infection and is left with a cough. So anything lasting less than 3 weeks is acute cough, and viral infections are the common cause for acute cough, but not always just the only cause. When do we call a cough chronic? Obviously, if it is more than 8 weeks duration. So acute cough is less than 3 weeks and chronic cough is more than 8 weeks. What about the duration in between? It's the gray zone. You can call it subacute, but we don't call it acute or chronic. Now, refractory cough. When do you cause refractory? Where a cause of the cough has been identified and it has been addressed appropriately with treatable traits. But the symptom may persist, the cough may persist despite treating the cause of the cough. That is called a refractory cough. What about refractory unexplained cough? When it is unexplained, there are no treatable traits. For example, somebody has upper airway resistance or upper airway cough syndrome. You've treated that, but the cough persists. You call it refractory cough. But where you can't find a reason for the cough and it is persistent despite treating it with all sorts of empirical treatments, you can call that cough as cause refractory unexplained chronic cough. What is cough hypersensitivity syndrome? This is a term which is being used more and more. It is characterized by troublesome coughing, which is triggered by low levels of thermal, mechanical, or chemical exposure. So it's a hypersensitivity cough, an allergic type of cough, not always necessarily atopic, but it can be because of thermal, mechanical, or chemical exposure, mediated by sensitization of the sensory neuronal pathway, which we'll be talking about a bit more as we go down. And it includes the vagus nerve and the central system activation. What about laryngeal hypersensitivity? This is again a neuronal hypersensitivity reaction cough, thought to underlie a range of laryngeal symptoms, which is chronic cough, inducible sudden laryngeal spasms, and thought to be mediated by vagal and CNS innervation. And we'll be talking more and more about these as we go on. So chronic cough, the prevalence is very difficult to diagnose, but in amongst various studies, it has been found to be in nearly 22% of the preschoolers and 10% of school-going children. And adult global population prevalence is approximately 10%. But that again varies, and again we will talk about some of the studies that have been done. So worldwide, initially it seemed to be more frequent in Europe and America than in Asia and Africa, and environmental factors were considered to be accountable for regional variation with urbanization in Western countries and inhalational exposures. But as all of you will agree with me that we are nowhere left behind with increasing urbanization, pollution of various forms, cough becomes a significant factor, especially in people who live in the cities. So these are some of the studies that showed that the prevalence was anywhere between 10% to 20% and somewhere even up to 30% prevalence. Well, these are in the Middle East countries, where this study, which was published in 2021, showed that physician diagnosed asthma was 6.7%, and chronic asthma was 5%. And all of these patients actually presented with cough. So cough was the presenting symptom. So this is just an asthma. And if you just start thinking about cough, that would cross anywhere between 30 to 40% of adult patients actually suffer from what we call cough variant asthma, and we will discuss that in a little bit. What is the impact of cough on the patients? Needless to say, it is very, very irritating, and it can present with a range of complications, causing impact on the health-related quality of life of the patient. In elderly ladies, in postmenopausal women, stress incontinence is a very, very irritating quality of life indicator, so much so that they stop socializing from fear of urinating every time they cough and having a bad smell around them. It can interfere with speech and eventually lead to depression and other quality of life related factors that reduce them socializing with each other just because of the cough. And the impact of cough can be assessed and quantified. We just think of cough as, oh, theek hai, khansi hai. But no, it can cause significant impact on the quality of life. And therefore, there's the Leicester Cough Questionnaire and the cough-specific questionnaire of life that can actually tell you how much impact it is having on a patient's life. So when patients come to us and they say they have a cough, we just think, okay, we'll give you this and then we'll give you that. But knowing what that cough is from and getting rid of that cough for them maybe will make you one of the better doctors compared to someone else that they go to. Because if you're treating them and they're not getting better, they will definitely seek a second and a third and a fourth opinion. Therefore, phenotyping cough, knowing what impact it is having on the patient and treating them is extremely important in today's day and age. So this is a very busy slide which shows that there can be intrathoracic, extrathoracic, and outside the thorax causes for cough. The most common pulmonary causes are asthma, non-asthmatic eosinophilic bronchitis, chronic bronchitis, bronchiectasis, drug-induced cough, and I'll discuss all these in details. The cardiovascular-wise, we know mitral stenosis and pulmonary hypertension itself is a common cause of cough. In the mediastinal lesions can cause cough, and apart from that, many, many other reasons. Extrathoracic cause, most common causes, rhinitis and sinusitis with a significant persistent postnasal drip, nasal polyps, oropharyngeal dysphagia, and laryngeal disorders and gastroesophageal reflux disease in upper GI are the most important GI causes of chronic cough. Central nervous system wise, although rare, but Guillain-Barré, which is the tic disorder, or psychogenic or habit cough are not very uncommonly seen in our practices.